hope this is on. Thank you for that very humble introduction. And I'll start by saying that right in the middle of the country operational plans in Uganda right now, it was very difficult for me to get cleared to come for this meeting. But having come for this meeting, a lot of what I'm hearing resonates so much with even my own personal experiences. So I have no regrets. And I will just very briefly share my own experience as a woman who is pursuing a career, moving from a medical doctor to a PhD and becoming a lawyer. My very first month in law school was one of the most disastrous in terms of discrimination and what I would consider actually stigma. And largely from the very seasoned advocates, the male advocates, who for every session, they asked me, what are you looking for in law school? You're extremely accomplished as a doctor. So what are you doing here? And having come from almost 20 years of HIV prevention, I thought the lawyers were doing a very bad job in public health. If you look at age of consent, if you look at gender-based violence, violence against children, the litigation for those very crucial aspects around the HIV response are extremely bad. So that was my resolve, and I'm hoping that as I get out of public health, I'm going to move into litigation for gender-based violence, violence against children, and all the bad laws that we see emerging, including the anti-homosexuality law in Uganda. So I'm not going to move into advocacy. Let me focus now on what actually brought me here. And my discussion is focusing around the future of HIV testing for girls and women. And for many of us who have been in the HIV prevention world for a while, we have seen the complexities around HIV testing, coming from the very standalone vertical HIV programs that were highly stigmatized. And then we moved into the HIV testing campaigns where we said test everybody. And those were not the best approach as well. And then we moved into integration into routine HIV counseling and testing. And then we moved into the discussions around we don't have all the money and we are doing so much testing. And we started saying, let's look at the yield, efficiency of testing, and the cost of testing. And then we moved into triage for testing. And then now we've come back to status neutral testing, where we are saying that we have come a long way and we are towards reaching the 95. So it makes no sense to talk about yield. It makes a lot of sense to talk about volume of testing, and it makes a lot of sense to make sure that you're offering testing within the context of comprehensive care and treatment programs. What's this? So that is briefly my presentation outline. I'm going to skip a lot of what has already been talked about. For example, the question around why focus on girls and women? We've had that right from the first session. I'm going to expand my discussion around what works best for women and girls in terms of HIV testing. What are the critical considerations, looking at facility versus community approaches, but also looking at HIV self-testing. And then I want to touch a little bit on how do you respond to a changing epidemic? How do you pivot based on data, based on the discussions around integration? When I was looking at the statistics around comorbidities, I was like, but where did we end with primary health care? Because these are the basics that we did in primary health care. But we verticalized HIV so much that we lost all the basics around managing patients from a patient-centered perspective. Then I'll talk a little bit about status neutral testing. So this is really a summary that I got from one of the very eloquent publications of Lynn that summarized status neutral testing. And in reality, between 2000 and 2020, we tested so many people, and the median time for a test reduced from about 10 years to about 2.5 years. So that means that our service delivery models are actually working. And we had a significant increase in the proportion of individuals who tested within a year. And of course, we also had a significant increase in the number of individuals that tested before their CD4 counts dropped significantly. When we're talking about advanced HIV disease right now, I think the proportions that we are getting are a little bit lower than we would have had if we wouldn't have moved to test and treat. These statistics are glaring, they have been repeated, but I think it's important that we repeat them. Overall, more women are living with HIV globally. But these global statistics actually deter us from the very optics around the populations that have been left behind. And one of those populations that is the focus of this conversation is actually women and girls. And for Uganda, the population survey actually showed us that we were not where we were boasting that we were, because our first 95 is actually far, far behind. And it is more significantly behind amongst the 25 to 34 and the 35 to 49 years of age. So when we are talking about aging with HIV, when we are talking about the early adapters and the late adapters, we for now do not know, unless we get the phylogenetic studies upscaled, we do not know whether the individuals that we are diagnosing with HIV above the age of 50 are actually new infections or whether they are late adapters. Recency testing is not even going to give us that answer. And how do we pivot our programs to make sure that it is reaching that age group? And this is again a typical example of data from Tanzania that clearly showed that the proportion of HIV positive women attending ANC who knew their status varied significantly by regions, from as high as 92% to 47%. And that speaks to the issue of knowing your epidemic, knowing where your populations are left behind, and knowing where they are located. And this is really just a schematic representation of that very data, clearly showing that about 30% of the women are unaware of their HIV status. And yet we've said that we've significantly increased our access to antenatal care. And this is another example from a meta-analysis from Ethiopia that again really concluded that we are at about only 80% of testing coverage amongst pregnant women, and yet this is a very low-hanging fruit. I will not talk to these statistics, but they speak volumes around some of the key barriers to access for women and girls in terms of when they experience their first sexual intercourse, when they have gender-based violence, the availability of contraceptives, and so forth. And this slide was shown again, highlighting the glaring barriers that we have to access for women and girls. And this is the 5x3 strategy, and I highlight health equity there. This is a PEPFAR strategy that is trying to make sure that we cover the gaps towards epidemic control. And those are the pillars and the strategic directions that we need to take. And health equity, of course, covers all the populations that have been left behind. So what approaches do we look at? One is that we need to have a strategic mix of modalities that focus on individuals that are most likely to be undiagnosed, those who are on ART and those who are most vulnerable to HIV infection. And the WHO guidelines very, very clearly stipulate that. So what are the critical considerations? One, adapt new approaches very quickly. When we are talking about lay providers, adapt that. When we are talking about status neutral, adapt that. When you're talking about HIV testing, adapt that. Then of course it is pointless to test people if you do not link them to ART. So what strategies do you have for linking women who test positive to ART as quickly as possible? Then of course there is a bigger question of misdiagnosis. Our misdiagnosis rates in Uganda at one point reached to about 20%. It's a different discussion when you misdiagnose someone who is HIV positive and negative. It's a different one when you diagnose someone who is HIV negative as positive. What interventions do you have for that? And then, of course, make very, very strategic choices. And those should be tough choices, balancing between the conversation of yield, the conversation of volume, and the conversation of cost. And then, of course, reinforcing the appropriate testing to the appropriate clinical settings, and whether it is community or facility testing. And evidence is something that we will always need. So an enabling environment that moves barriers is very important. I mentioned age of consent. We need to discriminalize, and we need to create an environment that is very, very patient-centered so that women can access ANC. Because if they don't go for ANC, then there's a whole missed opportunity to have them aware of their HIV status. And then this is what I summarize as a targeted approach to reach and diagnose girls and women. It needs to be very data-driven. We have to strategically use PITC. That's where we have the highest volumes of testing. We need to decide where we need to stop testing. We need to focus on diagnosing and undiagnosing the underserved. Women and girls is part of that. And then we need to avoid the reluctance to provide partner testing and index testing. We know that there are safety issues around partner testing, index testing, but let's deal with those safety issues and let's provide an intervention that works. And then let's legitimize the providers. I've tried to categorize what is effective for focused PITC, partner testing, and community approaches based on whether you are in a generalized epidemic or whether you are in a low epidemic. But again, at the end of the day, the message is know what your epidemic looks like. And this is really highlighting data from Uganda that shows that about 80% of our positives come from about 8 modalities. And if you look at ANC, ANC is one of the highest. So we need to optimize ANC as an approach to find women. And then for the community modalities, index testing remains very high and other modalities remain very high. And for community-based testing, we know that it's acceptable. Diagnosis is early. We find the missing populations. The cost is relatively high, but the positivity rate is also relatively low. And linkage to care becomes questionable. And we need to begin to realize the potential for HIV self-testing. Again, I have highlighted what would optimize the distribution of HIV testing at the facility level, whether you're using primary or secondary distribution. We need to begin to integrate HIV testing within the different platforms. Let's not run it as a standalone program. And how do we use the community peers to make sure that we broaden the level of awareness and distribution? And of course, there are new innovations, a lot in South Africa, I think, around the pharmacy models, around the use of coupons, around the use of dispensing machines. Innovation is what's going to help us to reach as many women and girls as possible. And of course, we need to begin to learn how to respond to a changing epidemic. We need to pivot on data integration. Community engagement is key, and then the focus on youth and adolescents. And then this is just highlighting a circle of how you need to begin to consider the update of your testing approaches based on what you're doing, evaluate, know your epidemic, and monitor the data. And then these are recommended approaches: integration, decentralization, and task shifting. And then this is a summary of what integration would look like. And then this is a specific focus on adolescents and youth. Don't implement modalities that you use for adult women in the youth. You'll find a description of what you need to do in this slide. And then, of course, this is still adolescents and youth, age of consent, quality, deal with stigma and discrimination, and then make them accessible services, including peer models. And then these are SNS strategies to reach female sex workers. Again, there's a lot of that in the literature. I have summarized it for you. And then status neutral testing is the last slide. How do we incorporate that into the current approaches that we are using? And where do we go from here? Let's define a shared vision. Let's collaborate better with the communities, and let's make sure that as countries we don't have a homogeneous approach. And then let's begin to adapt the new interventions that we know of. And thank you so much.